Alright guys, chapter 34. Here we go. Education standards, chapter objectives, key terms. Alright, we're going to go over the anatomy of the chest. General categories of chest injuries, specific chest injuries, assessment-based approach to chest trauma, summary, assessment, and care. Alright, EMTs Roxanne and Laura are on the scene of a patient who was ejected from the driver's seat of a vehicle that rolled multiple times after leaving the roadway at a high speed. As Roxanne maintains inline stabilization of the spine while opening the airway with a jaw thrust maneuver, Laura quickly exposes the chest and listens for breath sounds. No breath sounds on the right. There is jugular vein distension. What injuries are suggested by the mechanism of injury in the EMT's findings so far? All right. My immediate concern is there's no breath sounds and there's JVD. All right. So what immediate interventions are required? We need to maintain an open airway and use positive pressure ventilation. All right. Chest injuries may not have a dramatic appearance and they can be overlooked, but they are life-threatening. All right. Maintain a high index of suspicion based on the mechanism of injury. All right. So, the anatomy of the chest. It is a hollow area. The mediastinum is the middle of the thoracic cavity between the right and left lungs. The mediastinum houses the trachea, the vena cava, the aorta, the esophagus, and the heart. The visceral pleura is the innermost layer and is in contact with the lungs. The parietal pleura is the outermost layer and is in contact with the thoracic wall. These two layers are separated by serous fluid that provides lubrication to reduce friction between the two. All right. The reticular portion of the anterior chest, framed by the clavicles superiorly, midclavicular lines laterally, and the costal margins inferiorly, is referred to as the cardiac box. Any penetrating or blunt injury to this area dramatically increases the likelihood of cardiac or great vessel injury. If a puncture to the visceral pleura, the parietal pleura, or both pleura occur, the seal is broken and air is sucked into the pleural space each time the chest wall expands. As the pleural space expands, it creates pressure on the lungs and the lung collapses, leading to a pneumothorax. An open chest injury is the result of a penetrating chest wound caused by knife, gunshot, or wide variety of other objects, such as ice pick, screwdriver, letter openers, broken glass, nails, and car keys. An open chest wound can pull air into the thoracic cavity, sometimes with a noticeable sucking sound. This is referred to as a sucking chest wound. There are two problems in managing an open or sucking chest wound. One is preventing additional air from sucking into the chest cavity, and the other is avoiding trapping the air already in the chest cavity. What we're going to do is cover a sucking chest wound with your gloved hand when you first identify it, and then apply a non-porous dressing and tape it on three sides. This creates a flutter valve. It lets air out, but it does not let air back in. Covering a sucking chest wound with your gloved hand on first identifying it and then applying a non-porous dressing and taping it on three sides prevents both pulling in additional air and trapping that air that is already in the cavity. Open chest injuries may involve injuries to the heart, major blood vessels, can include a pneumothorax, can also interfere with the negative pressure needed for inhalation by allowing air to enter through the wound. All right, a large, unstable flail segment is life-threatening because it interferes with proper expansion of the chest cavity, limiting interthoracic pressure changes and leading to severe respiratory distress or inadequate respiration and rapid deterioration of your patient. All right, during inhalation and exhalation, the flail segment may display paradoxical or a seesaw movement. The flail segment moves in a direction opposite to the movement of the rest of the chest wall. All right, if there is splinting, the flail segment may not exhibit paradoxical chest wall movement. All right. Inhalation takes place when the chest expands, making pressure inside the chest less than the pressure outside, which causes air to draw in from the outside. The pressure that draws air into the expanded chest also moves the flail segment inward. Exhalation takes place when the pressure inside the chest becomes greater than the pressure outside of the chest, pushing air out of the lungs and decreasing the size of the chest. All right. The pressure that drives air out of the contracting chest also pushes the flail segment outward. The flail segment requires immediate recognition and management, but the underlying contusion to the lung is a more serious injury, resulting from blunt force applied to the chest. The flail segment prevents the chest from generating the normal negative pressure for inhalation. Stabilization of the segment can reduce the paradoxical movement. However, it can also compromise other chest wall motion and lead to the collapse of more lung tissue and alveoli. All right, because lung contusion and lung collapse are associated with the flail segment, continuous positive pressure CPAP or positive pressure ventilation using a BVM with supplemental oxygen is the ideal treatment. The amount of respiratory distress depends on the amount of damage to the lung tissue. Other signs and symptoms include dyspnea, cyanosis, and signs of blunt trauma to the chest. Emergency care is directed toward support of ventilation and maximizing oxygenation by delivery of high concentration of oxygen by non-rebreather mask. If supplemental oxygen alone cannot improve or maintain adequate oxygenation in the alert and spontaneously breathing patient who is in respiratory distress, using CPAP can improve oxygenation. Signs and symptoms of a pneumothorax include chest pain that worsens with deep inspiration, dyspnea, tachypnea, and decreased or absent breath sounds on the affected side. A pneumothorax is primarily identified by decreased or absent breath sounds from the side of the chest where the lung is partially or totally collapsed. If the patient with a pneumothorax is in a seated position, gravity can cause the air in the pleural space to move upward, and decreased breath sounds are heard in the apexes or the top of the lungs first. Symptoms of an open pneumothorax are the same as for a closed, except an open wound to the chest should be noted. An open pneumothorax is referred to as a sucking chest wound. All right. Rapid deterioration, severe respiratory distress, signs of shock, and absent breath sounds on one side of the chest should alert you to the possible tension pneumothorax. Other signs and symptoms include cyanosis, unequal movement of the chest, distended neck veins, diminished breath sounds on the opposite side of the injury, and the deviation of the trachea on the uninjured side. This tracheal deviation is a very late sign. You need to catch this before the trachea deviates. This condition might develop following the application of an occlusive dressing to an open chest wound. To alleviate the pressure by lifting the dressing and allowing air to escape during expiration, even if it is taped on only 3 sides. Bleeding in and around the lung commonly produces a pink or red frothy sputum when the patient coughs. Care is the same as for a pneumothorax and shock. All right. The bleeding usually originates from a lacerated blood vessel in the chest wall or chest cavity caused by penetrating objects or fractured ribs. Some of your signs and symptoms: bluish or purple discoloration of the face, head, neck, shoulders. All right, JVD, bloodshot eyes that protrude from the sockets, cyanotic or swollen tongue and lips, and bleeding from the conjunctiva. All right, we provide emergency care for any wounds to the chest and treat for shock. All right, signs and symptoms of cardiac contusion can include chest pain or discomfort. Signs of blunt trauma to the chest include bruising, swelling, crepitation, and deformity, tachycardia, and an irregular pulse. The patient can present with cardiac arrest. This is your comorbidus cordis. All right. The most common presenting rhythm is V-fib. Therefore, the applied AED will likely recommend defibrillation. A bruise can be noted to the center of the anterior chest wall. This comorbus cordis is sudden cardiac arrest from blunt force to the precordial area. All right, pericardial tamponade develops in 60 to 80% of stab wounds to the heart. And what it is it's bleeding around the heart. The heart is contained in that fiber sac, and there's bleeding inside that sac. It compresses the ventricles, resulting in inadequate ventricular filling and reduced cardiac output. Emergency care focuses on early recognition and rapid transport while maintaining an adequate airway and ventilation and maximizing oxygen by delivering a high concentration, either by a non-rebreather mask or BVM. Some of your signs and symptoms: you have JVD, signs of shock, cool, clammy skin, tachycardia, decreased blood pressure, narrow pulse pressure, weak pulses. Radial pulse will diminish on inhalation. The intercostal artery or vein can be lacerated because of the fractures and cause bleeding into the chest cavity. If a simple rib fracture is suspected, the patient usually presents in the guarded position, holding their arms over the injured site. You can use an arm to splint the injury by placing it over the injured site and applying a sling and swath to hold it in place. A patient who has a chest injury may appear relatively well at first, but can deteriorate suddenly and rapidly. The patient may not complain about a chest injury. In fact, in this scenario, the patient's chief complaint related to the chest pain is only shortness of breath. It is your responsibility to suspect a potential chest injury based on the mechanism of injury and a high index of suspicion to adequately assess the patient and provide necessary emergency medical care. All right, do not enter the scene of a shooting or stabbing until the police secure it and tell you that it is safe to enter. All right, while the scene is cleared of safety hazards, concentrate on the mechanism of injury. Ask bystanders to tell you what happened and look at your scene. All right. As soon as you determine that the scene is safe, proceed with the primary assessment. If spine injury is suspected, take the necessary spine motion restriction precautions. Form a general impression of the patient. Is the patient severely cyanotic? Do they appear to be in extreme respiratory distress? Are they breathing shallow and rapid? Are they holding their arms tightly against their chest to splint the movement? Do they appear to be in extreme pain? Are there any open wounds to the chest? Is the chest moving unevenly when they breathe? Do they appear to be in any extreme respiratory distress? Are they breathing slowly and rapidly? All right. If breathing is inadequate, apply oxygen as needed to maintain SpO2 equal to or greater than 94. Consider CPAP for your flail segment or pulmonary contusion. Do not use CPAP if a pneumothorax is suspected. Clothing can disguise a life-threatening sucking wound or flail segment. If the mechanism of injury indicates possible chest injury or the patient shows any signs of respiratory distress, quickly expose the chest and examine it. All right. Continue with the primary assessment and determine the patient's mental status. An altered mental status or unresponsiveness might be an indication of severe hypoxia resulting from an significant chest injury. Visually inspect the airway in the patient with an altered mental status. When assessing for tracheal deviation, palpate the trachea immediately above the suprasternal notch. All right, this is that little indentation immediately above the sternum. Inspection of the trachea rarely reveals the deviation. However, palpation might allow you to feel the abnormal shift prior to actually seeing it. The buildup of pressure in a tension pneumothorax can also cause the heart and large vessels to compress, causing decreased blood flow to the heart and ineffective pumping, which produces signs of shock, which is hypoperfusion. JVD and tracheal deviation are late signs of a tension pneumothorax. Paradoxical movement of the chest indicates a flail segment. One of the major complications associated with a flail segment is the inability of the patient to generate pressure changes in the chest necessary to adequately move air into the chest cavity. If the patient exhibits signs and symptoms of a flail segment with evidence of inadequate breathing, The ideal treatment is to provide positive pressure ventilation. Certain signs and symptoms may occur in major open or closed chest trauma. Many will be simultaneously. You will have cyanosis, dyspnea, tachycardia, bradycypnea, tachycypnea, obvious signs of injury, hemoptysis, which is coughing up blood, signs of shock and tracheal deviation, paradoxical movement, open wounds, subcutaneous emphysema. I swear there feels like, and you can hear it's when you press on their chest, it sounds like snap, crackle, pop. And I'm not really sure if y'all can hear this, but my dog is doing something in the bathroom in there. I don't know what she's doing. All right. You have JVD and absent or decreased breath sounds. All right, your secondary assessment. A sudden drop in the systolic blood pressure by greater than 10 milligrams of mercury during inhalation can be another sign of a tension pneumothorax or pericardial tamponade. The drop in systolic blood pressure during inhalation is referred to pulsus paradoxus. If at any time signs of inadequate breathing appears, immediately begin positive pressure ventilation with supplemental oxygen. Ventilation should be administered at a maximum of 10 to 12 per minute in an adult and 12 to 20 for an infant or child. Keep in mind that providing positive pressure ventilation can worsen a pneumothorax by forcing air out of the lung through the visceral pleura and into the pleural space. This increases the air in the pleural space, causing the lung to collapse further. If an impaled object is found, do not remove it. Stabilize the object with bulky gauze and bandages and prevent excessive movement. The exception in which removal is necessary are, there's only two. Number one, the impaled object impedes your ability to perform chest compressions in a pulseless patient, and the impaled object impedes your ability to establish and maintain an open airway. All right, increased respiratory distress, tachypnea, and severely decreased or absent breath sounds on the injured side are indicators of a tension pneumothorax. If an occlusive dressing has been applied and there are signs of developing tension pneumothorax, lift the dressing on exhalation. If respiratory distress and oxygenation can't be maintained with supplemental oxygen, apply CPAP to improve oxygenation if the patient meets the application criteria and no contraindications exist. It was previously recommended patients to be placed on the injured side or the chest wall be splinted to prevent outward movement. These procedures are no longer recommended because they can potentially impede chest wall movement and increase the amount of alveolar collapse, which worsens hypoxia. Y'all, this chick here looks like she is about to bomb somebody. She could have at least, I don't know. She looks demented. All right, a decreasing blood pressure, increasing heart rate, increasing respiratory rate, and cyanotic, cool, moist skin may indicate a worsening chest injury or shock from blood loss. All right, your case study. In the primary assessment, the EMTs find the patient responsive to pain with rapid, shallow respirations and a weak, rapid pulse that disappears on inspiration. Roxanne begins positive pressure ventilation as Laura requests ALS backup. With the assistance of other responders at the scene, the EMTs perform a rapid secondary assessment and package the patient for transport. The EMTs meet the ALS unit at the agreed upon point. Roxanne reports that ventilations are difficult. After a quick assessment, the paramedic performs a needle decompression, which immediately improves the patient's ventilatory status and circulation. The crew transports the patient to a trauma center where she undergoes surgery for chest and abdominal injuries as well as for multiple fractures. All right, does anybody have any questions? Please go over this in your book.